So I'm going to talk about, I think everyone has already heard so much about choosing wisely. So my job is very simple. I'll go through most of the things that have been said. I might not labor the point. But I want to tackle specifically on haemato-oncology and medical oncology. This is a bit specific to and a bit different from what was being talked about before. So I think this has been defined by Fidel very well. It's a concept that is well known. But let's focus on the second paragraph, which is Choosing Wisely Africa. It will make more sense, and it has a different meaning when we bring it closer home. It's an initiative that seeks to advance a dialogue on avoiding unnecessary medical tests, treatments, and procedures in cancer care in Africa. So again, this has been elaborated very well all the way from India, similar concept. There is the Philippines, there is the Brazil, and then there's this, which was a very landmark paper on the Lancet, talking about really demystifying the individualized cancer care and actually what is the cancer care landscape in Africa, with a very good recommendations. I'll really encourage you to read this paper. It talks about Africa in general when it comes to cancer care landscape. So in the spirit of individualized care and choosing wisely, we treat our patients using guidelines. And majority of them are, guidelines not developed by Africans and not for Africans. But, the biology might be the same, or people might say it might not even be the same. But one thing we're very sure that is not the same is the facilities and the treatment opportunities. That there's no doubt. Everything else might overlap, and still it might not actually overlap. So look at in terms of now talking about healthcare services and facilities availability. A minister in our continent might actually just have a $10 for his population to spend in all healthcare. Compare that to 150 million in the developing world. So really, there's a big, big difference. So how can we use those guidelines that have been developed in a country or in a minister who has 150 million compared to our own ministers who have only 10 million, okay? So that is just a question. I'm not saying we cannot use it, but it's just a food for thought, okay? Can we use that uniformity, really? And, as the famous Plato said, a shade of opinion or interpretation, Should this be just a whole universal thing that everyone follows? Or should we really individualize based on our resources, based on our capita income, and, based on our ethnicity and our individualized cancer landscape? So this is, again, the star here today is Fidel. We keep citing him and talking about him. And I will also add into the campaign, so this is the paper that we've all talked about. I'll not belabor the point. Those are the 10 points that you've had every speaker talking about today. And here they are, just to remind you. It is important, so I will go through it very fast. But I think the reason why we keep repeating is how important it is, okay? So don't, keep doing surveillance tests for patients who are okay, they don't have any symptoms. Do not decide on a potentially curable patient without input of MDT. We've talked about this is for the surgeons, don't just, I know you guys are knife happy, but, we need to make sure whatever we're doing is the right thing. Do not initiate treatment without doing staging. This is very important. Do not remove a breast lump without histological confirmation, because now, again, you'll have to do twice and do a completion surgery. So the patient might not really, agree to that. Don't treat low-risk cancer, prostate cancer specifically, without, talking about active surveillance. I think just to paint a picture for the audience, active surveillance is actually one of the modalities of treatment of early breast cancer. If the pathologists have classified this as low risk, the Gleason score is less than 7, the PSA is very low, and especially if the patient is very old, and they'll probably even die of something else than the prostate cancer, and they have this kind of low-risk profile, really we should think of active surveillance as a decision-making process. Do not delay palliative care, very important. It should actually, we've actually changed the term palliative care these days. We like calling it primary palliative care, which means we need to start right from the time of diagnosis. There's a connotation of palliative care with just hospice and sadness and end-of-life care. People, even including healthcare professions, they really do not understand the real meaning of palliative. It does not just mean someone who is about to go. It's actually making someone comfortable psychologically, physically, in terms of pain, psychological support, family support. That is what it encompasses. And it should not only be in the end of life care. It should be in the beginning of the diagnosis. So this is also, more drugs does not mean more efficacy. Sometimes you need to know who really needs those so many drugs, combinations. Sometimes even single agent might actually work for some diseases, as we're going to see. And then longer course of radiation. This has been mentioned, while one can work, really, there's no need for 8 or 10 of them. And that is because patient might not need it. Secondly, it's a stretch of the already meager resources we have. So there are many more patients who could actually benefit that time you're spending on this patient. And there's a waiting list. And we know in this neck of the woods, there are even very few radiotherapy machines. Okay. Now let's get into the nitty-gritty, since I'm talking about the medical oncology part. Okay, chemotherapy is topic number 1. This is, again, one that has been cited, combination therapy. I think we've touched about this. And then the exceptions for using multiple agents of chemotherapy is the ones I have written in red. Usually, testicular carcinoma, it's a disease that is known to respond to, probably good combination in a stable and fit patient, not, again, every testicular cancer. Large B-cell lymphoma, Hodgkin's lymphomas, acute leukemias, those ones may benefit from maybe the combined, well-established regimens. But again, it depends on patient profile. Targeted therapy. Should we give targeted therapy to everyone, left, right, and center? Targeted therapy is a very interesting, drug discovery based on the receptors. But really, if you do not have the receptor, why should we give? And don't forget, it's another cheap drugs. These are very expensive drugs. So poster child, just a bit of background for targeted therapy. There was this, how it came about. The investigators found in chronic myeloid leukemias that target. So this was the way the revolution of targeted therapy actually started, by using the famous drug imatinib, targeting a specific receptor. Antiemetics, you will imagine this, you want to give it as many as possible because you think actually your patient want to feel, not exactly, So patients who are given, antiemetics, not all of them will benefit actually. Depends on the regimen of chemo you're given. If it's ideally a very low hematogenic regimen, then you shouldn't be given all that, But there's delayed emesis. So delayed emesis, as you know, in many oncology personnel here in the meeting today, these are some of the drugs we use: the dexamethasones, the 5-HT3 ondansetrons, and all those. Now, more into hematology. ASH and an ASCO meeting have put this together, Choosing Wisely recommendation. Avoid routine preoperative blood test, This is for the surgeons. Not everyone actually needs a coagulation profile. Depends on their history and, probably the procedure and how long it will be, okay? Platelet transfusion, just because you're worried that the surgery might be very bleedy scene, doesn't mean that everyone needs. It depends on the count of preoperative blood platelets count, okay? The other thing is avoid thrombophilia testing in children with venous access associated and no positive family history. Really, this is not a very cheap test and shouldn't just be done all the time. Avoid red blood cells or basically transfusion for children with specifically iron deficiency anemia. Look at this. Doesn't mean the HB is as low as 5 or, if the patient is not going through immediate probably very invasive surgery that might further drop down the HB. If they're just symptomatic from iron deficiency and you've looked at that lab result, you know your MCV is on the lower side, the HB is low, patient is malnourished, you know their social background, maybe they don't get good food. Address that instead of transfusion. But in a life-threatening situation, of course, you will go ahead and transfuse. So these are, I think, one of the things I was talking about in hematology. So this was a very interesting study on transfusion. You know, this is out of Royal Marsden in the UK, and they looked at these hematologists or clinicians who really love just transfusion people. 2 packed RBCs every time they want to transfuse. So this also feeds into the Choosing Wisely initiative. There is honestly no written in bold law that says you must transfuse 2 pints every time someone has any kind of anemia, depending on the low level of the HB. So in terms of prostate, remember we talked about active surveillance in terms of prostate, but here is, don't do PSA test. This is very, I'm also guilty about this. A lot of people just order for PSA, and without understanding what to do with the result. The rule of oncology is do not do a test if you don't know what to do with the result. So because it's not cheap, it has a lot of patients just look at the positive, negative. They look at which number is high. Oh, it's higher than, and then you cause a lot of unnecessary anxiety for patients. So it should be there should be a reason for testing the PSA. So ASCO has done that, has taken an initiative with a patient who actually have a life expectancy fewer than 10 years should not be subjected to PSA because the harms are likely to outweigh the benefits. Okay. Similarly, Dr. Sidi is here. The Urology Society also talks about patients, with who are around 55 to 69, should actually be proposed for PSA. Not every man with a prostate, okay? Yes, so, and this is actually a very nice model that actually can calculate the risk for PSA or risk for prostate cancer, and then this should direct you or should guide you if there is need for PSA screening or not. Topic 6, we talk about imaging for early stage prostate cancer. I chose prostate cancer and, as you'll see, breast as well, because they're a bit common in our population. And these are the areas, these are the 2 cancers that really has a lot of gray area and maybe over diagnosis, or under diagnosis, or even the choosing wisely principle will work very well. So if the patient has early prostate cancer, there's no need for PET scans and bone scans, especially if they don't have bone pain. And even CT scan, if he's a very fairly fit gentleman in his 60s, he does not have a lot of urinary emergency symptoms, his PSA is very low, less than 10, and he's very fit, So you don't just do all this imaging just because you're worried about the thing. Breast cancer is similar. The following imaging tests are not used for staging, especially for, invasive carcinoma in situ, ductal carcinoma in situ. That's a precancerous lesion. And imagine if someone has that through a biopsy, it's been confirmed. A lot of people will be tempted to do PET CTs and bone scans and CT scans. And as Dr. Vanna was saying, just because the patient will never come back, so you're worried that they will never come back, and you want to do all these things, right? So DCIS, it's a carcinoma in situ. It's a precancerous lesion, usually amenable to surgery, and you need to counsel the patient and actually address their fear of cancer, and that this is not a full-blown cancer, rather it's a precancerous lesion. PET scans, I think I've already talked about this as a routine follow-up. We are even having issues with the CT scan, so how about even PET scan, which is even more expensive? I'm sure not many African countries have actually a PET scan. In Kenya, we're lucky now to have 2 centers with PET scan, but before, will you imagine we used to send patients for PET scan all the way to India just to do a PET scan before. So, imagine if you order that with all the transport cost involved, the PET scan itself involved, the cost of PET scan, the anxiety related to the results, and all that. So we need to really choose wisely on this PET scan. A lot of people love it. And actually, it has a high positive predictive value in many disease settings. It's actually good. But for example, if you're evaluating a solitary pulmonary nodule in the lung and you're staging for non-small cell lung cancer, the cancer recurrence evidence is high and cost-saving. But again, it should be individualized, and we should know who really needs it, not everyone. And as you know, PET scan is actually a poster child for lymphoma. We like doing it as a pre-chemo, and testing, and then interim testing in the middle to check if there's a response, and then later on when you finish. The only disease probably will really benefit from this is lymphoma, but still in our setting, we still do a good all chest, abdomen, pelvis CT. It's good enough. So those are some of them. And then more importantly, I want to talk about geriatric oncology. I think this is where it really fits into the whole choosing wisely thing, because this is a very unique population. They're very old. They really don't benefit from all these, testings, which some of them don't even change their life or even don't even alleviate the symptoms. Unlike prostate cancer, an old gentleman or a lady who has a low-risk prostate cancer, imagine if if he is subjected to all the things we talked about. So this is a very unique population, specifically, the older generation. I'm not saying we should underscreen them, but like the fact that they're old, that should actually, whichever test you do should be informed by their perception and their benefit versus the adverse risk, which is unwanted. So I want to bring it home specifically to how I practice in my own cancer center, where I work. Not that I own one, I would love to own one. So I work in a rural community cancer center in Kenya, which I take pride in because everyone is treated in the capital city, Nairobi. So this is, as I will show you shortly in the next slide, is almost 1,000 kilometers away from Nairobi. And when I got the job, I was like, I wasn't sure if I should go to a remote village, but I was like, why not, if it has everything that I can work with. So in that center, which is far away from Nairobi, we're actually doing very good, in my opinion. We have CT scan, we have MRI. Unfortunately, our biopsies, it's outsourced. We don't have an in-house pathologist, but there are companies who do that, and the turnaround time is a bit long, 2 weeks, but it's better than nothing. We also do chemos, palliative intent, or even adjuvant. We have radiotherapy machine, luckily, which is a Varian, a LINAC machine, so we can do 3D, VMAT, IMRT, all the good stuff. Health insurance, the uptake is a bit low, and we have a very unique cancer type, as I'm going to tell you in my center, in my population. So it's called the Garissa Cancer Center. That's where I work. This is the picture. It's not the current picture. It's the only picture I could get online. This is how it was built. And that's the map of Kenya, and the green part is where the Garissa province is. It's on the farthest corner of the country bordering Somalia. It's a county of around, give or take 1 million, around 800,000 population. It has started oncology clinic as late as 2019, can you imagine? So it's a very highly marginalized area, far from the activities that goes on in Nairobi. But it's nevertheless a very good center for the locals. Esophageal is the most common cancer in that community. For some reason, we're working on a research to find out why. So how do I practice choosing wisely, especially for esophageal cancer? Of course, we do biopsy. These ones are very important. I do not think choosing wisely can change that, because we need a biopsy with the OGD. We do scans. There are no PET scan anyway, and I don't see the need for it. So we do CT scan, chest, abdomen, pelvis as a metastatic screening. Histology confirmation is a must, and in my population, you almost never see adenocarcinoma. It's all squamous. But this is also in line with a lot of African population, and adenocarcinoma being very common in the West on the background of Barrett's esophagus and reflux disease. So almost my current practice is as almost all my patients get concurrent chemoradiotherapy. Unfortunately, they present in locally advanced stage. I barely see any early stage. So we do concurrent chemo rad, and I do not send my patient, even those with good pathological complete response, for surgery, because we literally do not have any surgeon who can do a proper job in terms of esophagectomy. And the local data has shown a lot of morbidity related to it and mortality. So you will take away 5 years from the patient that will have gotten from concurrent chemoradiotherapy if you send them to a surgeon. But I'm not saying we should not. It's only that we can't do it in my center or even in the country. PET scans, not on diagnosis because it's not even available, and it's very... breast cancer as another example, I will finish quickly. We biopsy all cases, so we follow Choosing Wisely case. We do not do, just a small biopsy. CT scan, again, we do that. We don't do PET scan a lot. Select cases, not on diagnosis. Histology confirmation, we do IHC marking, of course, which was one of the things we talked about in Choosing Wisely. Do not start chemo or, for example, endocrine therapy while you don't even know if this tumor is actually hormonal receptor positive. We generally have few surgeons, but most of them are general surgeons. We do not have a specific breast oncologist. So most of our general surgeons are the ones who do mastectomies. Chemotherapy, this is a common practice across the country, taxanes. We do not have these newer molecular CDK4s, so we mostly use first line, second line chemo, but the uptake of endocrine therapy is very good. Radiotherapy, we still use the conventional 25 fraction in 50 gray because of local context and due to late presentation and loss to follow-up. I'm a bit guilty on this because one of the recommendations from Choosing Wisely was don't do things just because the patient will be lost to follow-up. But I think I speak from the ground. I still believe this might be an exception that they still get 50 gray because you'll never see them again. They will actually really go away. So conclusions, we believe that healthcare delivery is transitioning from volume-based to value-based. I think this is very important. We shouldn't be proud of how many cases we treat every year, but we should be proud of how are you treating them, okay? And that is basically what Choosing Wisely is, I think. So emphasis is on the discussion on the ways to select more cost-effective and high-volume treatment and interventions and to minimize financial toxicity. And finally, Africa is very large. People think Africa is the same. We're a very heterogeneous community with a different healthcare infrastructure. I was just talking to Professor Mustafa Dieng. In Senegal, they have only 4 LINAC machines. In Kenya, we all have 14, but I'm sure it's not enough still. And some countries, they don't even have the radiotherapy machine. So it's a very heterogeneous health services or health system paradigms. There's a lot of similarities, though, in terms of research resources and practice setting. And with that, I thank you very well. Thank you.